We're going to be talking about fractures of the femur and knee. In this talk, we'll go over femoral head fractures, hip fractures, femoral shaft fractures, distal femur fractures, patella fractures, and tibial plateau fractures. Before we talk about femoral head fractures, keep in mind that these are always high-energy injuries, as the hip is a highly concentric joint and has both bony and stout soft tissue restraints to dislocation. These fractures are always associated with a hip dislocation. If you actually look at all hip dislocations, about 7% have an associated femoral head fracture. The Pipkin classification is important because it also dictates treatment. A Pipkin type 1 has a small inferior head fragment and is in the non-weight bearing portion. Type 2s are above the fovea and involve the weight-bearing portion. Type 3 are associated with a femoral neck fracture, and these have a devastating impact on the longevity of the femoral head due to a double hit in both the femoral neck and the femoral head in terms of its blood supply. Type 4s are either type 1 or type 2 that are associated with the posterior wall acetabulum fracture. Any incongruity in a type 2 needs surgery, as the hip does not tolerate malreduction well. Remember that an anterior approach will not further compromise the blood supply to the femoral head for these injuries. An anterior approach actually gives good visualization of the femoral head fragment, as they're typically anterior and inferior. For Pipkin type 3s, in younger patients, ORIF should be considered, and an arthroplasty should be considered in more older patients. Approaches is controversial for type 4s. You would think that with a posterior wall and a hip dislocation that you'd want to go posterior to fix the wall and also fix the femoral head. However, these can be fixed again through an anterior approach, and then an EUA can be performed of the posterior wall to determine if the hip is unstable. Alternatively, a posterior approach can be taken with a trochanteric osteotomy and a femoral head and a hip dislocation to visualize the femoral head fracture. This is a 35-year-old male who sustained a Pipkin type 4 femoral head fracture dislocation. His fracture is infrafoveal and he has an associated posterior wall acetabulum fracture. A posterior approach through a Coker-Langen bag was taken and the trochanteric osteotomy was performed. A surgical hip dislocation was then performed and the femoral head was reduced with 2 screws that were countersunk. Following this, the posterior wall acetabulum fracture was fixed. Here are the OKU highlights for femoral head fractures. Femoral neck fractures, like most orthopedic injuries, again have a bimodal distribution. Let's talk about femoral neck fractures in the young. Any fracture to the femoral neck will compromise the blood supply to the femoral head, either through a hematoma or direct disruption of the vessels. The blood supply to the femoral head comes through the medial femoral circumflex artery that courses over the quadratus femoris and goes proximal. The lateral circumflex artery and the ligamentum teres do not play as major of a role in blood supply. The Powell's classification is typically used to describe fractures for the femoral neck in young patients. From type 1 to type 3, the classification goes from a more horizontal to a more vertical pattern. Keep in mind that patients with young femoral necks can also get stress fractures in this region. These are typically diagnosed on MRI and requires a T1 weighted image. As a fracture line from Powell's classification becomes increasingly vertical, there's a higher risk and incidence of complications. This is because the more vertical the fracture line, the higher the shear forces are across the hip. On average, patients under 50 typically have a 60-degree vertical line and comminution in the neck inferiorly and posteriorly. However, these patients also have tensile failure anteriorly, which leads to a clean break there. This is typically what is used to get a reduction read through an open approach for femoral neck fractures. These fractures are technically surgical emergencies, but should only be done when the patient is stable and resources are available, aka not in the middle of the night. Again, the most important factor in success that is controlled by the surgeon is quality of the reduction. Reduction can be done through an anterior approach or a lateral approach. Through either approach, a capsular decompression can also be performed. Fixation also plays a role in successful treatment of these injuries. The more vertical the fracture, the higher the failure rate of cannulated screws, unless a Powell screw is added. This is a transverse screw that runs perpendicular to the fracture to compress the vertical fracture line. The preferred fixation is a sliding hip screw. There has been an increasing trend in the usage of an inferior buttress plate. However, there is limited clinical data on its usage. These injuries have a high complication rate, with osteonecrosis rates and non-union rates in a 10 to 20% range, and can even be higher in certain studies. Even with good reduction, shortening as well as varus can occur as the sliding hip compresses. The shorter the femoral neck, the worse the outcomes are due to its effect on the abductors. The following risk factors are important to memorize for non-union, as they are often tested. To treat non-unions of the femoral neck, your options are a total hip replacement or to do a valgus intertrochanteric osteotomy. Through this, a vertical fracture line can become horizontal, thus allowing it to compress and mitigate the non-union risk. It is important to note that the head has to be viable for this to be an option. Osteonecrosis is correlated directly with fracture displacement. The more displacement initially, the higher the rate of risk of osteonecrosis. This is a 25-year-old male who sustained a displaced femoral neck fracture. He was reduced through closed reduction means, and a sliding hip screw with derotational screws was used as an implant of choice. Again, it's not exactly the type of implant that is used which is important, but also the quality of the reduction is the most important thing that goes along with treatment of these injuries. Here are OKU highlights about femoral neck fractures in young adults. Geriatric fractures, however, are different than young femoral neck fractures. These are low-energy injuries, and treatment options are also different. Unless there is significant medical complication that prevents the patient from not tolerating surgery or the patient is completely non-ambulatory, they should be fixed or operated on. Surgery is based on displacement and physiological age, not chronological age. Non-displaced or valgus-impacted fractures get treated with cannulated screws and an inverted triangle configuration. Oftentimes, if there's enough space or if there's significant posterior comminution, a fourth screw can be placed. A sliding hip screw for this type of injury in a geriatric population is a much more involved procedure with increased blood loss and actually higher rates of osteonecrosis without any benefit. A technical question that is often asked is a starting point for the inferior screw in an inverted triangle configuration. It is important that it does not start below the lesser trochanter, as this can lead to a stress riser that leads to a subtrochanteric femur fracture. Arthroplasty is reserved for displaced fractures in the physiologically older patients. The more active and high-demand patients are, as well as those with pre-existing arthritis, should get a total hip replacement. The outcomes, despite a higher dislocation rate, are better for total hip replacements compared to a hemiarthroplasty. Furthermore, a hemiarthroplasty has a finite lifespan and may need a revision in the future. For the purposes of the test, in discussing hemiarthroplasty, an uncemented hemiarthroplasty will never be the right answer, as the complication rates are significantly higher in both subsidence and also in terms of intra-op and postoperative fracture. Furthermore, while bipolar hemiarthroplasty is theoretically more stable, there are no differences in clinical studies, and bipolar is much more expensive. With regards to surgical approach, the posterior approach has a higher rate of dislocation. However, the anterolateral approach, which has a lower risk of dislocation, has a higher level of abductor weakness. These are two things that will be often tested on the exam. Here are the OKU highlights regarding femoral neck fractures in the geriatric population. Extracapsular hip fractures are seen more often in more frail patients. However, unlike femoral neck fractures, they have a much higher healing rate. This is due to the extracapsular nature and with robust blood supply in the area. The goal for any hip fracture is surgery within 48 hours. Ideally, the sooner the better. When asked about co-management models, patients treated with this will have improved outcomes, decreased length of stay, and faster time to the OR. The classification is simple. These fractures are either stable or unstable, and this depends on radiographic markers. Unstable fractures include subtrochanteric extension, large posteromedial fragments, reverse obliquity fracture patterns, and now more scrutinized is a lateral wall, which is measured about 2 centimeters distal to the vastus ridge. Lateral walls that are less than 15 millimeters are considered incompetent. The classification also helps guide implant choice, as the two implant choices that are often used are a sliding hip screw or a cephalomedullary nail. The intramedullary nail acts as a buttress and can substitute a lateral thin wall. Its application is percutaneous. Theoretically, long intramedullary nails splint the entire bone. However, when comparing short versus long nails, recent changes in nail design have noted no difference in peri-implant fracture. Longer nails are associated with longer procedure times, increased EBL, and increased cost. Essentially, what has been determined through studies are stable fractures should get a sliding hip screw, and unstable fractures should get an intramedullary nail. If using a sliding hip screw for a thin lateral wall, make sure a trochanteric stabilization plate is added, as this will mitigate this risk of fracture of the lateral thin wall. The cephalomedullary lag screw should reach the center position, as this is the best bone in the femoral head. A tip apex distance in both nails and sliding hip screws should be less than 25 millimeters, as this can successfully mitigate failure. With terms of sliding hip screws, there is no difference in 2-hole versus 4-hole plates. Note that in unstable fractures, as the lag screw slides along the barrel, the shaft will tend to medialize, which causes adverse changes in the mechanics of the hip joint, and for this reason, sliding hip screws should be avoided in unstable fractures. Another key concept that is tested for lag screws is the tendency of these screws to create an apex anterior deformity in left hips. This is because as the screw is turned clockwise in a left hip, the femoral neck or the intertroch region will flex. Treatment, and to avoid this, is to advance the screw past the disordant point and then turn back. Reverse obliquity patterns are tested frequently on the exam. The answer to this is to never use a sliding hip screw. A blade plate can be used, however the most commonly used implant is a cephalomedullary nail. For these fractures, the goal is to have a tip apex distance of less than 25 and reduction in the sense that the proximal femur needs to have an anatomic versus slightly valgus alignment. The intercalary and intermediate fragments do not have to be anatomically reduced. So avoiding varus and having an appropriate tip apex, most extracapsular hip fractures will not fail and will go on to healing. A much more challenging subset of proximal femur fractures are subtrochanteric femur fractures. Again, these have a bimodal distribution in age, but the deforming forces across the hip make them challenging to treat. The proximal fragment is flexed, externally rotated, and abducted due to the iliopsoas, short external rotators, and abductors. These forces make healing and maintaining reduction in this area challenging, and due to these high biomechanical forces, risk of implant failure and non-union is high. The treatment is intramedullary nail. The start point doesn't matter, as it can both be used successfully as either a greater troch or a piriformis nail. For a greater troch nail, the more medial you start on the tip of the troch, the less likely the valgus bend proximally will kick you into varus. The goals of surgery are to minimize flexion, but more importantly to minimize varus. If closed reduction means or open reduction means are unable to get the fracture reduced, blocking screws can be placed to counteract flexion and varus, but placing the screws medial and posterior in the proximal fragment respectively. Here are the OKU points for subtroch femur fractures. For the purpose of this test, it is important to know the major and minor criteria for bisphosphonate femur fractures. Furthermore, do not forget to obtain contralateral femur imaging and ask for prodromal symptoms on the contralateral extremity, as there can be impending fractures there. These fractures have proximal femur remodeling and a thick lateral cortex that extends intramedullary that needs to be cored out in order for the proximal femur to maintain its alignment. Because of the changes that occur through chronic bisphosphonate use, prolonged healing time is common with these fractures. It is important to consider an MRI of the contralateral limb if there are prodromal symptoms or if there are changes consistent on radiographs, and there is an increased risk of iatrogenic fractures with intramedullary nerve fixation of these injuries. Femoral shaft fractures will often be tested in the setting of polytrauma patients. The goal of treatment is fixation in less than 24 hours. These fractures are often associated with other injuries, so it is important to look at markers for resuscitation. This includes pH levels, lactate, and base deficit. Early fixation and stabilization leads to less thromboembolic and pulmonary complications. Keep in mind that intramedullary nailing is safe when there is a head injury as long as appropriate intracranial monitoring is being performed. If there is any question of stability or the patient's resuscitation status, X-fix is the answer. Ipsilateral femoral neck fractures occur in 1 to 9% of patients and are missed about 30% of the time. Preoperative hip, AP, and lateral radiographs, as well as a CT scan, if possible, should be scrutinized to avoid missing this injury, as this can have devastating consequences. The gold standard in treatment of these injuries is a statically locked antegrade ream nail. Reaming is better, and this is especially as the reamer designs have changed over time. Reamers now have deep flutes and a thin reamer diameter, so the reamer doesn't act like a plunger, causing pulmonary issues. Reaming leads to higher union rates, shorter time to union, lower perioperative complications without any difference in mortality and ARDS, and union rates are as high as 95%. Nails can be placed either piriformis or trochanteric start. Keep in mind that if not perfectly placed, especially through a piriformis start point, can cause negative consequences. An anterior start point can cause an iatrogenic fracture in the proximal femur through hoop stresses. A posterior start point can lead to anterior perforation distally, and a medial start point can lead to a fracture of the femoral neck. Ultimately, there are no differences between the two start points, as there was concern about abductor dysfunction in patients with trochanteric start points. However, a cadaveric study demonstrated equivalent damage, if not more, in a piriformis start point for antegrade nails. It is important to understand the pros and cons associated with each nail, but ultimately it is surgeon preference. While we do not have long-term studies on the effects of retrograde nailing, they do play a role in stabilization of femoral shaft fractures. The start point is technically easier to obtain, especially in obese patients. The patient is positioned supine and does not require a fracture table, so it is ease of positioning for polytrauma patients. One of the indications is bilateral shaft fractures, as it can be nailed without having to reprep and drape. While this is not an absolute indication, distal third fractures of the femoral shaft tend to be easier to be managed through a retrograde nail. The start point for these nails is just anterior to Blumenstadt's line on the lateral and on an AP down the canal in line with the anatomic axis of the femur. However, the start point for these nails will be through articular cartilage, which may not be through a weight-bearing portion. However, we do not have long-term studies regarding the effects of this. When treating fractures with associated femoral neck injuries, use of one implant such as a recon nail, especially if the femoral neck is displaced, can lead to high failure rates. It is important to treat each injury with one implant. Bilateral femur fractures are a significant hit to the patient metabolically. If a patient is unstable or cannot tolerate both femurs, it is better to X-fix both, or if the patient is able to tolerate one femur, fix one femur, check resuscitation markers, and if safe, fix the other, or X-fix the other, or X-fix the contralateral limb. Studies have shown that you can safely convert an X-fix to a nail within 2 weeks of placement without any increase in infection risk. Malrotation is one of the most litigated complications associated with femoral shaft fractures. Patients with GSW and comminuted fractures have higher rates of malrotation and malunion due to the reliable lack of coracal keys in terms of reduction. Malrotation should be set as the same as the contralateral side. However, the goal is to have less than 15 degrees, as less than 15 degrees is generally well tolerated within the population. Rotational profiling can be done through 3 different methods intraoperatively. One is a scanogram technique, when the lateral of the knee is taken and then 15 degrees of anteversion is set to the lateral of the hip with the C-arm. Lesser troch profiles can be compared and coracal keys can be used to assure that the patient's rotation is relatively well set compared to contralateral side. Understand that positioning plays a role in malrotation and should be accounted for intraoperatively. It is noted that patients tend to tolerate internal rotation degrees better than external rotation malrotation. A commonly tested concept is correction of malrotation in femur fractures. The easiest way I think of this is to neutralize the distal femur. So the image on the left, labeled B, the distal femur is at neutral and there's 10 degrees of anteversion on the hip. For the image on the right, you neutralize the distal femur and then check the amount of anteversion proximally. For this patient, this would add more version proximally. After this, you calculate the difference of version each side and determine where the rotational deformity is and what needs to be done to correct this. Here is the OKU section on femur fractures. Distal femur fractures again have a bimodal distribution. These are high energy injuries in young patients and often have significant soft tissue or ligamentous injury associated with it. In the geriatric population, there are lower energy injuries. They are challenging to treat due to a variety of reasons. The distal femur has a trapezoidal anatomy, which makes fluoroscopy challenging. Furthermore, the anatomic and the mechanical axes of the distal femur do not line up. Lastly, in geriatric patients, the distal femur tends to be relatively osteopenic or osteoporotic. Fractures are classified as extra-articular, partial articular, or complete articular. Treatment options include nail plate, and temporizing X-fix. X-fix is important in treating injuries with extensive soft tissue damage, open fractures, fractures with vascular injury, and dislocations where length is required prior to fully understanding the nature of the injury. If X-fix is placed followed by definitive surgery, again within less than 2 weeks, there's a high rate of union and a low infection rate. Treatment is done in a systematic way. Stabilize articular block, then connect it with the shaft to reestablish alignment, which can be checked by measuring the lateral distal femoral angle with regards to the alignment of the distal femur. It is important in complete articular injuries that the implant choice should be a fixed angle plate. If a fixed angle plate is not used for these injuries, there's a higher risk of varus failure. Partial articular fragments requires a buttress plate. and these fractures do not require lock plating. However, type C fractures, if plated, require lock plating. True indications to a plate include insufficient bone stock distally, periprosthetic fractures around a closed box or a stemmed implant, periprosthetic fractures around a total knee with a total hip proximally. Plating has to be done in such a way that the construct is not too stiff. A construct requires a long working length. At a minimum, an 8-hole plate should be used. There should be a balanced spread of screws proximally with a combination of locking screws and non-locking screws. Keep in mind that locking screws work as an internal X-fix and non-locking screws will bring the plate to the bone. Avoid excessive exposure and stripping at the fracture site, as this is a watershed area. The plate has to be placed in the appropriate position distally, which is anterolateral. If the plate is placed posterior, it will create a golf club deformity where the distal femur will medialize and malrotate. To prevent excessive strain, far cortical locking screws are designed to decrease stiffness at the fracture site. However, these have had limited use clinically. Essentially, the more stiff the construct, the more likely it is to fail. Intramedullary retrograde nailing has taken popularity in treatment of these fractures. The strength of the nail and fixation of distal femur fractures depends on the number and the orientation of the distal interlocks. Furthermore, the quality of the purchase of these interlocks is very important. The greater the number of screws placed distally, aka it requires 4 polyaxial screws, the more biomechanically similar it is to a lock plate. Keep in mind that retrograde nailing is associated with increased knee pain. Despite the various methods of treatment, there is a significant non-union rate. Open fractures, patients with obesity, stiffer implants or stainless steel implants, infection, diabetes, and decreased plate length are all associated with non-union of these injuries. Again, take a look at the patient on the right. There are locking screws placed adjacent to the fracture, and there is a non-balanced use of screws in the proximal segment. This will lead to a non-union. Lastly, it is important not to end the plate in a stress riser region, such as the subtrochanteric region. Here are the OKU highlights for distal femur fractures. We'll now talk about patella fractures. The patella has a convex shape along the articular surface that allows it to articulate with a particular patellar groove. The fractures are classified by a pattern, which can also determine the integrity of the extensor mechanism. The patella is an important part of the extensor mechanism, and loss of the patella can lead to a decrease in 1/3 of the strength of the knee. So, think of the fracture pattern, determine if the fracture needs surgery, and based on this, how it should be fixed. Fractures are either transverse, simple, or multifragmentary. Non-operative treatment can be done in patients with minimally displaced or non-displaced fractures. There should be an intact extensor mechanism so the patient can straight leg raise. Treatment is typically a hinge knee brace locked in extension and then progressive range of motion, which is usually around 4 to 6 weeks. Furthermore, these patients can be made weight bearing as tolerated. There are multiple configurations for fixation, the strongest being cannulated screws with tension band wiring. For severely comminuted fractures, consider a mesh plate. Keep in mind that tension band wiring alone with K-wires has a failure rate of about 22%. A partial patellectomy can be done when the inferior fold of the patella is severely comminuted and does not allow for fixation. The patellar tendon can be passed through bone tunnels in the patella, but it is important to reattach the patellar tendon anteriorly to avoid tilting of the patella. However, a complete patellectomy or a patellectomy involving more than 30% of the patella should be avoided, as this can have some serious consequences to the patellofemoral mechanics. Patella fractures have a relatively high complication rate. Anterior knee pain is very common, and hardware removal is very high due to the subcutaneous nature of the implants. The biggest risk factor for a poor outcome is patella baja. Elective hardware removal can be as common as 33% in certain studies. Again, keep in mind certain implant configurations have a higher failure rate than others. Let's now talk about tibial plateau fractures. The tibial plateau is concave medially and convex laterally, and the lateral plateau tends to sit higher than the medial side. Here we have the OTA classification and the Schatzker classification, which are both reliably used to classify plateau fractures. The OTA classification is consisted of A, B, and C. A is extra-articular, B is partial articular, and C is complete articular. The Schatzker classification, Schatzker 1 through 3, are lateral-sided injuries and are typically less high-energy injuries. 4 through 6 are high-energy injuries, and 4s are associated with knee dislocations. With these injuries, think about damage to neurological structures as well as risk for compartment syndrome. External fixation plays an important role in maintaining length and reduction as well as soft tissue monitoring, especially in the higher energy Schatzker classification, such as 4, 5, and 6. These patients are at an increased risk of compartment syndrome, and this typically involves the anterolateral compartments. These patients should also have ABIs if pulses are asymmetric, and a CT angio should be obtained if ABI is less than 0.9. Tibial plateaus have a high incidence of associated ligament injuries. MRI studies demonstrate multiple soft tissue injuries associated with these fractures. However, the clinical significance of these are unknown. Keep in mind that up to 50% of lateral split depressions have peripheral meniscus tears. These meniscus tears are clinically more displaced in fractures that are depressed greater than 1 to 1.5 centimeters. Non-operative management is reserved for minimally to non-displaced fractures with a stable joint. Keep in mind that medial fractures tend to be closely monitored as varus alignment leads to poor outcome. Unicondylar fractures require buttress plate. Especially in lateral plateau fractures, lock plating is not necessary in these injuries. The larger the depression laterally, the higher the rate of a clinically significant meniscal injury. What is really important is restoration of the joint stability and alignment. Articular reduction, while important, is secondary to this. For these injuries, a bone void filler is often used after cartilage is tamped back up. Calcium phosphate is stronger than allograft and calcium sulfate. However, keep in mind that calcium sulfate can lead to wound drainage and complications, as they tend to absorb within 2 to 6 weeks. Bicondylar plateaus, on the other hand, are much more challenging and different. Bicondylar plateaus typically need 2 plates, a buttress plate along the medial side and a locked lateral plate. When treating bicondylar fractures with 1 plate, a locked lateral plate is absolutely necessary. However, keep in mind, without a medial buttress, they can continue to drift into varus. It is important to avoid soft tissue stripping and to use minimally invasive techniques if possible. When performing submuscular plating on the lateral side for longer plates greater than 11 holes, the superficial perineal nerve can get damaged, so an open approach to this area should be taken to avoid damage to the nerve. The classic sequence for this is to fix the lateral plateau and then to build a medial plateau and then build a lateral plateau back up to it. Again, due to the high nature of these injuries, there is a relatively high infection rate in bicondylar plateaus, and this is elevated even more with acute compartment syndrome. Articular subsidence occurs commonly in the geriatric population, and knee stiffness is a common complaint as well. While post-traumatic arthritis is relatively high in 5 to 7 years, A lot of patients do not require total knee replacements. What is truly important is restoration of joint stability and the mechanical axis. Thank you.